Hey. So you a vibe like that and you wanted to do defe?
I wanted to hide it.
Why? But Joshua, you can dance. Why do you choose defe?
Oh, I don't know how to dance.
Is it true?
I don't know.
Yeah. Like Joshua is shy. Joshua, are you shy?
A little.
A little bit?
Yeah.
Okay. Why, your wife is watching us?
Oh, I don't have a wife.
Your girlfriend is watching?
I don't have a girlfriend.
You go stop this attack thing. What about you, Eugene? Your girlfriend is watching?
Yes, please.
I like that. Now, I love the fact that you are Jesse Life Clinic. You're coming here today to help us with something that, for me in particular, I've been asking questions on it. We have so many people, at no fault of theirs, they get stroke. And when they get stroke, is the care at that time. Some people, you meet them and they'll tell you, I've had stroke before, but if you look at me right now, you can't tell. And there are those who have been in it, they don't have the help that they need to have, and they struggle to even get back to their normal lives. And so you are here to help us through this conversation, and I'm excited about it. So welcome once again.
Thank you.
Thank you very much.
So let me start this conversation with you, Joshua. People often say stroke has no cure. Now, how true is this? Is it true that stroke has no cure?
Okay, so to a large extent, and depends on your definition of cure.
Okay.
So we manage the situation, yes. But if you look at function in general, you can actually work on function and possibly get 100% or even close to 100% as well. But if you're talking of the pathology, that's the influence of the disease condition on the cells, that one, you cannot get it back.
How? Please explain.
So for instance, when you have certain cells in the brain,
Okay.
which are dead, now you can't get it back again.
Oh, you can't get that back?
Yes.
So when you have memory loss, that is it?
No. So the brain cells, what happens in stroke is there is something called neuroplasticity. So the brain has to reorient itself and reorganize itself to take over those functions as well. So when you have memory loss, for instance, with the occupational therapist, they take you through some therapies that should help you in terms of the memory.
Right.
aspect. Yeah.
Okay.
But I mean, the cellular aspect or the tissue that has been damaged, that is it.
That is it?
Yes.
For good? Wow. So now it's understandable. But the fact that you can be able to help with the memory coming back is even good enough, right? And then you can also help with mobility as well, right?
Yes.
Okay, so now let's walk us through the things that you have to do if you're first self-diagnosed with stroke. Maybe there's somebody watching. Let me start from, the root, because we talk about stroke, but some people don't even know what causes stroke. So maybe we should start from that side. So maybe, Eugene, let me ask you this one. If we really talk about stroke, what are we talking about?
So stroke is a condition whereby blood flow to the brain is obstructed or prevented. So it could be ischemic, it could be hemorrhagic. So ischemic is when oxygen is being blocked, reaching to the brain, and hemorrhagic is when there's the rupture in the blood vessel. So that's the causes of stroke.
Okay.
And we have certain risk factors that could, let's say, let someone get stroke. We're talking about hypertension, talking about physical inactivity, talking about smoking, and not eating healthy.
Not eating healthy?
Yes. So these are the risk factors of getting stroke. So you asked the first question about, can a person recover fully? My say is, it depends on the severity of the injury, the age of the person, and also the time when the person started the therapy as well. Thank you.
Okay, that's what it did. So Eugene is actually an occupational therapist, and so he's dealt with a lot of stroke patients, right? How many stroke patients have you dealt with?
A lot. I can't.
You can't
mention.
count?
Yes.
Wow. And for you, Joshua, you are a physiotherapist.
Yes.
And you've also dealt with a lot of stroke patients. Okay.
And still counting.
And still counting?
Yes.
Right, so there is actually a woman that I think that we saw a video of it. That's the reason why we even called you, because when we saw the video, we're like, listen, everybody at home who probably has a relative or a friend must hear of this good news and get this necessary help. Very, very important. So when the person gets stroke and the person visits either your facility or any other facility, your facility is Jesse Life Clinic, and the person visits that place, some people would have had stroke for a very long period before they come in, maybe 10 years before they come for help. Others, immediately they see the first signs, they come in. Can you help somebody who has had stroke for a very long time?
Yes, we can. So studies actually shows that there's no end to recovery. So even after 6 months, although usually the first month to the 6th month is when you can see drastic improvement, even after the 6th month, you can still see significant improvement with therapy as well.
So when should one come in if they are diagnosed with stroke? Okay,
so it depends on the point of diagnosis. So once you notice the cardinal signs of stroke, so that's from the face, for instance, the slurring speech, you quickly rush to the hospital, meaning the emergency, hospital and emergency setup. So they stabilize the person medically. And from the point of, that's what you call the acute care, from that point, we, the physiotherapists, the occupational therapists, speech therapists, as well, we come together as a team with the medical doctors or the physicians and attend to the client from that point throughout their journey and to the point of discharge. Upon discharge, the person has to continue more of the rehabilitation process whilst going for reviews from the medical doctors as well.
Oh, okay.
Yes.
So person will still do the medical doctors, and then what are the things that now you do practically within the rehabilitation period?
Okay, sure. So you mentioned that assuming someone had stroke for 10 years, my take on that is research has proven that from the early stages up to 6 months, that's when the muscles are ready. Let's say they can respond to treatment. Taking 10 years, the muscle will be plateaued. The rate at which you recover might be hard.
Okay.
To require effort from us, the therapists. Yes. So for me, I would say treatment will start from the very day you'll be diagnosed. Yeah. That's where we come in, we do your positioning, we educate you. Yes, how to do transferring, how to move and all that, because any fall can cause a further injury. Yes, please.
Okay.
Sure. So for me as an occupational therapist, I'm focusing more on the occupations because as we are all here, we've dressed, we bathed, we walked here. So all these activities is also part of people having stroke. How they dress, how they eat, how they even walk here, starting from their cognitive aspect. Before you even dress, you knowing where your dress is even the task. Going for it, matching it with your shoes, all these are occupations. So my role is to make sure you are able to dress or do your activities independently.
Okay.
That's occupational therapy.
All right.
Yes, please.
So then what? You help with the memory?
So, yes, please.
Okay.
So let's take it this way. I'm starting with the physical impairment. Assuming one is having one-sided weakness, and the person is presenting with, let's say, poor trunk control. When the person sits, maybe the person will tilt to the left side.
Right.
The hand is not able to move, but you have to dress. So we have a strategy that you can start dressing from the affected side. Yes, you dress the affected side before you dress the unaffected. Okay. So it's a strategy. And we have ways that we can train you to dress in bed as well, and how to bath. If you require an assistive device, we also come in. Let's say a stroke patient will go to the washroom and is having balance issues. Definitely, he or she will need some support. So I will prescribe, let's say, a grab bar at the washroom to provide stability. So it's an assistive device. Okay. That's my role.
Okay.
Yes.
Oh, right.
Taking the cognitive aspects, someone with memory loss, my role is to plan a routine. Maybe throughout the week, what a person will do, maybe we'll get a table or activities that will go in. So let's say Mondays, you will do this, Tuesday, you do that, with time and alarm. Yes, so that will help the routine with someone with cognitive issue as well. And planning, let's say if you are supposed to dress, I will make sure, let's say in your wardrobe, I will start from, let's say, your singlets, boxes coming. So I will number it in a way that you will dress and it will fit.
And you want to rather teach maybe an assistant to help the person dress?
It depends on the level of, let's say, function of the person.
Okay.
If the person is not able or is not having power to do that, definitely it will require an assistant. Okay. So with some people, no matter what you do, the person will be dependent. But I'm talking about people who have, let's say, muscle power, the trunk control is good, the cognitive is picking up, the function is, gaining. Yes, you can do something about that. Yeah.
See, we have Dr. Jerry also joining us on Zoom. Dr. Jerry Osei Alomele. He is also a medical doctor at Jesse Life Clinic. And so if he's on, hi, Dr. Jerry.
Hi.
Good afternoon. How are you?
Good afternoon. I'm very well. Yourself?
I'm doing well too, and thank you so much for joining us on Zoom. I know there are so many people logged on for this conversation because there are people who are going through this and they don't know how to recover. The word should not be recover, but rather the rehabilitation process that they need to be on. And so thank you for this. For any patient who has stroke and the patient comes to you, what would be the first thing that you tell the patient for rehabilitation process?
Okay, so regarding stroke management, as the other panelists said earlier, once the stroke has occurred, there's really not much we can do about it to reverse the stroke itself. So the changes that have gone on in the head, the brain, all those changes are permanent. There's nothing you can really do about those. But in terms of improving the overall quality of life of the patients, post-stroke, that is one of the key things that we want to do, as well as preventive measures to ensure that we don't have another occurrence of the stroke, because we know that research has shown that having one stroke increases the likelihood of you having another. Okay, so usually when it comes to stroke management, those are the two key areas that we as doctors seek to target. So trying to prevent the stroke with medications, controlling whatever risk factor may have precipitated the first stroke. So if it may be hypertension, poorly controlled blood pressures, if it was abnormal lipid levels in the blood, if it was poorly controlled diabetes, etc., we try to get that under control. Then we also want to try and put the patients on other medications to prevent the stroke from happening again. So depending on the type of stroke that you have, we do that as well. And then we also want to give something to help with cognition, okay, because we know that there have been damages or there have been changes that have
to the brain, right?
Occurred within the brain, yes. So we want to put the patients on some medications to try and help improve the nerve function, so that if there is any impairment in level of consciousness or cognition, ability to reason, ability to think, some of those, the damage that may have occurred will be minimized. We don't have the other surrounding brain tissue also being involved, which will further worsen things. Right. Then, regarding rehabilitation, it is very important. As the others have already mentioned, it's very important because science has shown that the earlier we start rehabilitation, the earlier it is for the brain to be able to find alternative ways of performing the same function that it was. So different parts of the brain can perform different functions. So if a certain part is damaged, God in his wisdom created the brain such that it can find an alternative pathway on an alternative route to still perform those functions that have been lost. So we usually encourage our stroke patients to start physiotherapy as soon as possible. The earlier, we always say the earlier, the better. So there have been some certain stroke patients, yes, they come with significant weakness. They are not able to walk initially, but with physiotherapy, occupational therapy, etc., you see them a year or two later, they are working on their own. It's not as though the changes that have occurred in the brain have reversed, but then with exercise and other things, the brain has been challenged to find an alternative way of still providing the necessary function. So as doctors, as clinicians, we always encourage our stroke patients to start as soon as possible, especially once they become stable, they are more conscious, they are well-oriented, they're able to communicate well. We let them know that. If they are not too stable, we usually want to hold on, make sure they are as stable as possible, before we start with the rehabilitative processes.
Right. But is there hope for those who have had it for a period?
So different studies show different things. So the longer the stroke, the rehabilitation process starts after the stroke. So the earlier we start the rehabilitation process, the better the chances of full recovery. The longer we wait, the more the brain becomes adapted to that particular function. And so it becomes a bit more challenging to reverse functionality. So they reduce or reverse the reduced function. So it's not, I wouldn't say that it's a complete no, but the likelihood of having the patient going back to normal function will reduce significantly if we keep waiting long and long. So there are certain patients the family will tell you that, oh, he had a stroke maybe 5-6 years ago. You ask, was any physiotherapy or rehabilitative interventions done? Nothing of the sort. And you see that this patient's hands, his limbs, his lower limbs are stiff, very rigid. When you touch it, he's not willing to allow you to do anything. His face is deviated, it's all over the place. He's looking, as we say in local parlance, like a vegetable. Prognosis not looking good. And then because he's not so functional now, he becomes a burden on his caregivers.
Right.
They leave him, he's neglected. And then now it's the other things. Okay, usually in the teaching, when it comes to stroke, the concept is it's not the stroke itself that will kill the patient. It's the other things, the comorbidities, the associated things that come with the stroke. And so this neglect that I'm talking about, this person can become hungry, have low blood sugars, and die from that. Become very dehydrated, infections can set in, etc., etc. So usually we encourage our stroke patients to start the physiotherapy as soon as possible. And this soon as possible is relative to the period or the time period at which they are very stable and they can tolerate the gruesome exercises by the rehabilitative team. Right. The thing about the rehabilitation is that it's not easy. So we usually try to...
If you say it's not easy, are you saying it's painful?
It can be, it's not painful, but it can be a bit challenging. And some of these individuals, especially someone could have been a bank manager who was walking about in his car, walking about, doing everything, and all of a sudden he's now bedridden, cannot walk, cannot speak. It can take some time for such a person to get used to the fact that this is now his, in quotes, new state.
But is there a possibility such a person can walk again?
Well, there's a possibility.
With a rehabilitation process, right? With
a rehabilitation process, and depending on how much of the brain is affected. So there's a possibility. There have been a lot of cases, so that it is very possible for that to happen.
There are people who do traditional medicine alongside. Is it advisable?
This question. Okay, so there's a role for traditional medicine. But I would always say we cannot take away traditional medicine from our society. It's enshrined in our way of life and our culture. But I personally believe that in as much as you are doing your traditional medicine, okay, let's also add the orthodox medicine to it. That is my personal opinion. It's not anything that has been shown from any study or anything of the sort. But that's my personal opinion.
Okay.
So you want to do your traditional medicine, or whatever, herbs, etc., no problem. But in as much as they are doing that, they are still doing what doctors and other clinicians have set forth as a plan for you. And we never know.
You never know.
So everything working together can produce good results.
Maybe. So Joshua now comes in as a physiotherapist, right? Yes. Now, Joshua, from all I'm hearing, it's easier to work on somebody who just got a stroke than somebody who has stayed for a longer period, right?
Comparatively.
Comparatively, okay.
Severity.
Okay.
So someone may just have had a stroke maybe a week ago, but the severity might be quite high, where there's a lot of brain damage. Also, the type of stroke is another factor as well. Okay. And someone may have had a stroke for...
What are some of the types we have?
So, as Eugene said, you have the hemorrhagic stroke and an infarctive stroke.
Okay.
So the hemorrhagic is when there's a rupture in the brain, which is quite lethal. But in terms of recovery, it's much
it's easier
as compared to ischemic.
Really?
Yes, comparatively. Just that the probability of you meeting the creator is higher with that.
Okay.
Yes.
And what causes that one?
So usually from BP, the blood pressures.
Okay, causes that one.
That causes the rupture. Or some people may have aneurysms, among other conditions. But usually,
you're using big terms.
So aneurysm is, for instance, when I take, this pure water that they used to sell penny to penny. You see, when you fill it with the water and you tie it, you can press them and then it bulges out.
Okay.
So that's what happens in the blood vessels. I'm just trying to use that to relate how aneurysm looks like. So when it bulges out, you realize that the weakest point is those bulges.
Okay.
That's what happens with aneurysm. So some people may be walking around, they have aneurysms in their head. And then you don't know, the least thing you do, it just ruptures and then you're having a bleed in the head.
Okay.
So that's another example as well. So that's very lethal. But in terms of recovery, once you're stable, you can recover much faster. And also the amount or the amount of brain cells that has been destroyed. Okay. That's another factor. At the same time, the positioning as well, how the patient was handled is another key factor because from my experience, the way you position the patient will actually show if there will be significant improvement or not. So we have something called shoulder subluxation, when the shoulder bone drops down. So usually you see some clients who have been poorly handled with stroke having that wide gap in their shoulder as well. So from the onset on the ward or in the emergency or even the ICU, I also have the discussion as a physiotherapist with the relatives as well, teach them our position, even the caregivers.
What's the right position? Can we get somebody so that you teach us the right position? Please come.
Okay.
Every time we use you.
So if you could,
what's the right
chair, or you can sit in this chair.
Yes, you can sit in this chair.
Okay, so it depends on the position.
Okay.
If it's lying, you have the position as well.
He can lie on the floor. It's fine. It's carpeted.
Okay.
You have to demonstrate.
Okay, sure, I'll do that as well. So the positioning is both from the physiotherapist and the occupational therapist, so we work as a team as well. So assuming, it's an assumption, you have a left-sided weakness as well. Everything is very loose. What I do is that I always urge the relatives or the caregivers to get a lot of pillows.
Okay.
A lot. So one I'll do is, first and foremost, I have to secure the bone here in the socket as well. Place it properly. So come closer to this chair. Go this way. So I place it here. Then like this. This is quite short. So what I do is I top it up this way, the other one as well. Then I make sure that the wrist is well positioned this way because it's easy for them to have wrist drop as well. And over a long period of time, spasticity begins to form over here. So the normal pattern of stroke, usually, I'm using this, the left, is this way.
Right.
And then the leg is this way.
Okay.
So that's the normal pattern. So it's what you are trying to do to prevent it from occurring. So you have to make sure you extend here as well, positioning properly to prevent the subluxation there as well.
Okay.
Then you make sure that the person is well seated. You have pillows well stuffed at the back to give him extra support as well. Then the legs, you make sure that it's 90 degrees on the ground as well.
Okay.
So in lying down as well, what you try to do is foot drop.
Please teach us the lying down. He's here, he will lie down.
Okay, sure. So I'll illustrate the pattern of stroke first, then you can appreciate it as well. So when you see a stroke client, I'm assuming it's my left side. They walk this way.
Okay. Okay.
Like the feet.
Okay.
That's how they walk.
Okay.
And then the reason why they walk is because of the spasticity as well. And there are some compensatory movements in the body. That's why they tend to walk that way.
Okay.
So the reason why I had to rotate my leg this way, and then when I move this like this, is because the hip flexors, that's the muscle responsible for raising the leg up this way, is weak.
Okay.
It's not...
so the leg is always positioned to that side?
Yeah, so in order to compensate, for me to move in front, naturally, if I have weak hip flexors, I'm not able to move this way. I just have to rotate it this way.
Okay.
The hip adductors, that's responsible for adding.
Right.
So remember, adding is this way. And abductors, that's AB, away.
Okay.
So the hip abductors, the adductors are quite stronger comparatively. So one way to compensate, remember, poor hip flexion, adductor strong. So what do? I have to compensate by rotating this way.
Yeah.
Then when I do this, I'm literally adding it to myself, remember?
Okay.
That's why they work that way.
Okay.
So in order to correct that, we as physiotherapists, sometimes I see things on the media and then it's quite sad, the information that is being pumped out as well, especially by our fellow, I'll mention them.
Some people, yeah.
Our fellow people. Yeah, it's quite sad because they end up smearing items on their hands and stuff. And based on what I'm explaining, no amount of ointments or item you pour on the person, or even medication, will change that physical appearance. At best, we can do. The medication is meant.
The herbal medicines can't help. You know, there are these herbal leaves that they put on them.
It won't do anything at all. Because this is a functional problem.
Okay.
So let me explain to you why the herbal medication will not work at all.
Okay.
We were all born, we couldn't write, right? We couldn't dress up on our own. So in order for you to be able to write, you had to go to school. Your teacher will hold your hand and take the pen or pencil and trace over and over and over and over. So you do it over and over and over. So your brain rewires to learn that task. We didn't know how to type till Mavis Beacon came in and she helped us to type. So they're practicing over and over and over. So once you lose a function, it's all about redoing it over and over and over again.
Oh, right.
So no amount of herbal or special thing will make you. Yes. This is where we have to get it right.
Okay. Makes sense. Makes sense.
So until you've practiced and rehearsed it over and over. So repetition is one key thing we as physiotherapists and occupational therapists use in our task.
So you work hand in hand?
Yes. So it's always back and forth. We always discuss among ourselves.
You can't work alone?
So I can work alone. So it depends on the situation.
Okay.
And well, with physiotherapy and occupational therapy, there are some overlaps at certain points. So where there's an overlap, I can easily cover for that.
Okay.
As well. But where is...
Say overlap. What kind of overlap are we talking about?
So in terms of our scope of practice or our practice jurisdiction, there's certain overlaps. For instance, balance training.
Okay.
I can train balance. The occupational therapist can train balance as well.
All right.
But it depends on the extent. If it's quite intense, it's more physiotherapy. Okay. Cognitive stuff, memory.
The memory.
I do
and the depression? What about depression?
So it's occupational therapy.
When
it comes to more of mental health, I push you to the occupational therapist. Oh. When it's more of physical movement, intensive stuff, it's more physiotherapy as well.
Okay. Now let's do the lying down. Okay. You know. The practical of it. Don't worry, it's sweat. The place is sweat. It's neat.
Okay, sure.
Yes. Okay.
Okay, so Eugene will take over that part.
So Eugene, this is where you come in, right?
Both of us
can do it.
Okay.
Yes. Supine, back.
So let's say somebody has stroke and you want to put the person down, right?
Yes.
Okay, or the person was lying down and the person got a stroke.
Definitely. Okay. So the thing is, whenever we come to the ward, we'll meet you in line, most likely.
Okay.
We'll most likely meet you in line. So each of the positions and how we position the arm as well to try and help prevent subluxation and other issues as well.
Okay.
Yeah, so Eugene?
All right, so this is a supine position. That's you lying on your back. So the first thing that we target is the hand.
Okay.
So we make sure the hand is not dangling or being off from the bed.
Okay.
So we use pillows. Because normally they have edema and swelling in the hand.
Okay.
The upper extremity to the lower extremity. So you do positioning. That's the first intervention for stroke rehab. So you make sure the wrist is up, as my brother said, just to prevent fluid from accumulating in the wrist or the hand. Okay. So this way, so that it drains back.
Oh, sure. Okay.
And some people too will be having foot drop, as in the feet, yes.
Okay, if it drops like that.
Plantar flex like that, yes.
Okay. So what? Then it means that the joints, the joints of the bone becomes weakened.
So
yes. Go ahead.
Since you work together, you see the way I get to answer.
I know.
So definitely, when there's weakness, muscles covers the joints. Okay. So when the muscles are weak, definitely the joints
will break. Okay.
And let's not forget, the stroke is the part of the brain that's sending the electrical signal. So let's take it like ECG or the grid, the national grid. So we have, let's say, the head being the northern region, the hand being votal region, the leg being any other region. So once something happens to the that region, the electrical impulse or signals being powered there has an issue, it means there's nothing going on. Nothing is going to power it. That's the whole idea behind the weakness there. So once we are able to find ways and means to connect or use a generator, then we can start getting that power.
Okay. So the leg, now what do we do?
So that one, assuming, let's use this one. So this is the stronger side.
Right.
And this is the weaker side. So you make sure you use pillows as well, just to push the leg in this position, not to cause a drop like that. So just to position it at a normal.
So use the pillows to push it. Can you use a table to chuck it?
No, please.
Why?
Pillows are used in bed, honestly.
Okay.
Yes, please. And let's not forget, a stroke patient cannot lie flat like this on the bed. So
long period of time.
Yes, please.
Okay.
So we try to elevate the top.
So we can use the cushion to elevate to see how it will be like.
We are just assuming.
Yeah, we are just assuming, yes. Okay, so this is how
yes.
Yeah. The reason being that we don't also want them, we also don't want them to aspirate or choke on their saliva as well. If not, they can also pass out because of that. So especially when the person has issues with swallowing as well. So that's when, if the person has issues with swallowing, we also call the speech and language therapists as well to also do their part. They do their assessment as well, but that's for their aspect as well. So we work together as a team.
Okay. Charlie, this one there, thank you so much for coming today. You can go. Come. You can go. Thank you so much. Dr. Jerry is still online, but maybe I should find out where, definitely people are asking where you are located so they can come over, because this is a life-saving conversation.
Yes.
Yeah.
So we are located at New Achimota, just behind the Melcom building, close to the St. Thomas More Catholic Church.
Okay. All right. Is there a number they can call?
020-1300-714 or 020-1300-715.
Is it only stroke patients that you handle, or there are other chronic diseases that you handle?
We handle a wide array of conditions. Wide. So stroke is just one neurological condition.
All right.
Parkinson's.
You handle Parkinson's?
Yes, a whole lot.
Wow.
So Alzheimer's, dementia.
You handle dementia?
Yes.
Wow.
Yeah, Alzheimer's, dementia, even with children, cerebral palsy, autism.
Wow.
A whole lot of conditions, we handle them as well. People who have what you call deconditioning, when they walk a little, they're tired. We also handle all of them as well. People with respiratory issues as well, that will need rehabilitation. So in Ghana here, we don't really have what you call pulmonary rehabilitation.
Okay.
So unfortunately, sometimes from the chest clinic or once you are discharged, they tell you to go back home. But ideally, you are supposed to undergo some form of rehabilitation. We take you through an exercise program to prevent, and that actually prevents or minimizes your rate of readmission as well. So evidence shows that those who undergo rehab, that's physiotherapy or occupational therapy, your rate of readmission or even death after chronic conditions is much lower as well.
Wow.
So we see a lot of conditions, a lot.
That's nice. And Doc is on. Doc, before you go, anything you want to say? Maybe we left something out.
I think everything is fine. The most important thing is to try and, in as much as we are talking about physiotherapy and all these things, I think the most important thing is to try and prevent the stroke. That's the most important thing. But if inadvertently the stroke comes up, early reporting to the hospital and then the early physiotherapy would improve overall outcomes. I think that's the most important point for today's session.
All right, Dr. Jerry, thank you so much for joining us. Eugene, anything you want to say? I hear there's a message that has come on WhatsApp. There's a question, so we'll have to answer that question before we go. People wanted to send in a lot of questions, but unfortunately, time. So Eugene, before you go.
Okay, so what I can say is that rehab is the one-stop strategy for all kinds of condition, be it neurological, physical, emotional. That's where I target.
The emotional part comes in,
Yes. So we take you through a series of exercises. We use your interest. Assuming someone having stroke and she likes reading or she likes to cook, definitely I have to use that strategy to get attention.
Okay.
Get it. So I would say OTs or occupational therapists will help much in the daily activities, how you can go by what to do.
And you have speech therapists as well that can help you regain your speech again.
And swallowing issues as well.
And swallowing issues. Okay. If we can have the question from, WhatsApp, so that I can ask the question before we go. Do we have the question? All right, so we are trying to get a question and then, all right, so hello. Are there any stroke treatments that require surgery? I once heard that some strokes are caused by a torn vein in another part of the body. How true is that? Reverend Obi, he's here.
I see.
He's not here. Hey, so he's watching us from home. Oh, wow. Thank you. Okay.
So is Jerry still online or?
Jerry's good.
Okay, then I can answer it. So,
okay.
Yes, some strokes require surgery, especially if it's very fatal. And if, for instance, your stroke is caused by aneurysm, as I said earlier, that one, straight away, you have to do the surgery.
Okay.
Yeah, so it depends on the kind of stroke as well. But for the torn vein, I think there's an issue with that side. Torn vein, it won't necessarily cause a stroke per se.
Okay.
Yeah, if it's an artery rupture or anything, unless there's clot. If there's a clot in the vein, that one, you need immediate attention to. That one, we give you some, what you call hemolytics to try and break down the clot as well.
Okay.
Then it should be much better.
Fantastic. Eugene and Joshua, thank you so much for being here. We are very grateful. The number again before you go.
Okay, so Jesse Life Clinic, the number is 020-1300-714.
All right.
Or 020-1300-715.
Thank you so much for coming. And this is a life-saving conversation we've had. Thank you. And so if you know anybody who is struggling with not just stroke, but Parkinson's disease, dementia, Alzheimer's, arthritis, cerebral palsy, all of that, please go to Jesse Life Clinic. They will definitely take good care of you.